All right, hi everybody. So this week we're going to be covering social problems in health and healthcare. So to begin, we're going to take a look at kind of the three big demographic features that sociologists are always interested in studying, which is socioeconomic status, race, and gender. And we're going to look at how all three of those different demographics impact and intersect health and healthcare in distinct ways. Unsurprisingly, as we'll unveil as we're working through that discussion, we'll see that marginalized groups in all of those sectors, so poor people, people of color, and women typically kind of get inferior health treatment and have worse health outcomes in comparison to the privileged groups, although there is some nuance to that, particularly within the gender section, which we'll talk about. So then after we look at health disparities across those kind of demographic factors, we'll take a closer look at some of the specific issues tied to the current healthcare system that we have in the United States, specifically in terms of our healthcare coverage. We're going to look at how the United States spends money on private insurance versus another of countries comparatively around the world that rely more on public healthcare coverage. And we'll look at the implications of that. And then, as always, we'll wrap this discussion up looking at some ways in which we can address some of these issues pertaining to health and healthcare, especially in our current situation related to the COVID-19 pandemic. All right, so let's talk a little bit about social class and health. This will be somewhat of a review as we talked about some of these implications and connections when we talked about socioeconomic status and poverty earlier in the semester, but it's probably not surprising to you to find that being poor is strongly associated with poor health outcomes. There's a number of factors that contribute to this. Poor people, in comparison to wealthier people, are more likely to have higher levels of stress. And what studies have consistently found in the medical area, in the medical fields, is that higher levels of stress are correlated with virtually every type of preventable disease. People with more stress tend to have higher blood pressure results to higher likelihood of having heart disease. Higher levels of stress are associated with many types of cancer. Higher levels of stress also associated with higher levels of mental illnesses, and obviously mental health has impacts on your physical health. So being more stressed contributes to a number of negative health outcomes, and obviously being poor, worrying about living paycheck to paycheck is a very stressful condition for many individuals to experience, which has negative effects on their physical health as well. In comparison to wealthier people, poor people are also more likely to live in unsafe and unhealthy environments. And we'll talk a little bit more about this in a couple of weeks when we talk about social problems related to the environment, but poor people are more likely to live in dangerous neighborhoods that have higher rates of crime, oftentimes because housing is more affordable in those areas. So living in unsafe places puts you at greater risk of getting harmed physically in that way. Also, poor people are more likely to live next to environmental hazards and experience higher rates of pollution in the neighborhoods that they live in. There's a really interesting podcast that I listened to about a year ago about this particular neighborhood in Chicago that was in the poor, predominantly African-American part of southern Chicago. And this neighborhood actually had a landfill built right in the middle of housing, right? This landfill. So a lot of these people in that area were getting sick. They were getting exposed to different toxins in the air, a lot of kind of like dust and from like cement that was being produced through the construction of building this property, and then of course just living literally around garbage right in the middle of their neighborhood. And you can almost guarantee that that dump would never have been considered a feasible thing to build on the Gold Coast in Chicago, right, in the wealthier neighborhoods there. So living in unsafe and unhealthy environments is associated with people of lower socioeconomic status. Poor people also have inadequate access to health insurance and healthcare, and we'll talk about much more of this later on in this presentation. But the U.S., we currently rely on a private healthcare system, private insurance system, which essentially means that every individual is required to purchase private health insurance. Some individuals are able to purchase private health insurance more affordably through their employers, but many employers, especially those that cater to lower class jobs, hourly jobs, things like working in customer service, working in restaurants, etc., very rarely afford or offer their employers health insurance through their employment, which means that employers in those lower socioeconomic status jobs have to pay more out of pocket for private insurance, and private insurance can be so insanely expensive that many poor people just forego getting health insurance altogether, which of course puts them at risk of not getting treatment when they need it. And then lastly, poor people are more likely to be uneducated about different risk factors of diseases. So for example, some people may assume that it's just common knowledge that drinking, smoking, not exercising, eating unhealthy foods are more likely to contribute to poor health outcomes. But that's learned information, right? If you didn't go to school, if you went to a poor school that didn't teach you about health, if you went to school that didn't have a health class, for example, how would you learn those behaviors and know to avoid engaging in them, right? So for all of these reasons and many more, we can see that socioeconomic status is largely connected to health outcomes, and that poor people are more likely to be burdened with poor health. Race also plays a significant factor in health outcomes, and we talked a little bit about this during our discussion on race and racism in the United States, but people of color tend to have worse health outcomes than whites, even among those with the same incomes. So that's to say, even when we hold socioeconomic status as a constant, we still see that people of color end up having worse health outcomes in comparison to white people. And a few different explanations that we can apply sociologically to describe why this may be. The first is that there's an added stress of living in a racist society. Excuse me, right? So even if you are a person of color that comes from a wealthy family, you have high levels of income, every day you still need to live with the stressor of dealing with prejudice and discrimination because we live in a society that's built on racist tendencies, right? So that added stress of constantly having to deal with prejudice, constantly having to fight against discrimination, never knowing if you're going to get pulled over by a police officer and how they're going to treat you, never knowing if when you go shopping, if an associate's going to follow you around the store, all of those little kind of stressors and the microaggressions that people of color predominantly experience add up to their stress, which likely contributes to one of the reasons why African Americans are more likely to die from heart disease in comparison to white people. Right? African Americans and Latinos who have experienced the most racial discrimination in their daily lives tend to have worse physical health. And again, it's likely a result of the added stress that discrimination forces upon those individuals. Poor people of color are more likely to live in urban areas and other locations that are unhealthy places because of air and water pollution, hazardous waste, and other environmental problems. So this is just kind of shows how, again, race obviously intersects with socioeconomic status. Since people of color are more likely to be poor and live in poverty, they're also more likely to live in these more dangerous and unhealthy environments. And again, this is something we'll talk more about in a couple of weeks. And lastly, let's look at some intersections between gender and health outcomes. And we talked about this in previous weeks when we talked about toxic masculinity and then also about misogyny. And when it comes to health, it's kind of this an interesting realm sociologically to look at, because we see women and men experiencing kind of disadvantages in healthcare simultaneously. So while women are an oppressed and marginalized group and they do kind of bear the brunt of negative outcomes in health, there's kind of a distinct group of social problems pertaining to health that men experience, and those are largely related to toxic masculinity. So by and large, women still, on average, live longer than men. Women's life expectancy is about 6 years longer than men, which sounds like a good thing. But despite that, women also still receive inferior treatment from healthcare professionals in comparison to men. I assigned a reading this week that goes into more detail about this and cites some more studies that support this claim, but what research consistently finds is that women are taken less seriously by healthcare providers when they go in and report experiencing any sort of symptoms or ailments that they may have. So much so, actually, that women are more likely to die on operating room tables than men are. And a lot of the research is finding that this is because when women go in and report symptoms, say for some treatable or preventable condition, healthcare providers will typically not take them seriously. They'll say, oh no, I think you're fine. I don't think it's that. Just go home, take some ibuprofen and wait it out. And what we're seeing as a result is that when doctors finally do take women seriously when they come and report symptoms, often for example, women with cancer, their cancer is advanced to stages that make it more difficult or impossible to treat because healthcare providers didn't listen to women initially when they came in. Also, women are less likely to be treated for heart attacks in comparison to men, because similar to the way in which men experience unique symptoms of depression, women also experience unique symptoms when they're experiencing a heart attack. And so healthcare providers are predominantly trained to treat and diagnose symptoms according to men, because the healthcare industry, again, being built in a patriarchal society, predominantly dominated by men, and a lot of the research about that medical experts use to diagnose and treat and assess symptoms are conducted with male patients. So we don't necessarily have kind of a gender equal educational system that teaches healthcare providers the unique experiences and symptoms that women might have for many different diseases, because the medical world is largely viewed through a men's lens. So women are disadvantaged in that way. However, men, as we talked about during our discussion on toxic masculinity a few weeks ago, men still experience some disadvantages in health and healthcare, but it's largely those disadvantages are largely products of toxic masculinity and the way we socialize men and young boys in the United States. So, for example, men are reluctant to discuss and seek help for their medical problems due to toxic masculinity. We socialize young boys to be the strong and silent type, so never complain if you're experiencing any pain, just rub some dirt in it, you'll be fine, etc. Another negative aspect of toxic masculinity in the way we socialize boys is that we encourage men to live unhealthy lifestyles, especially in comparison to women. For example, men smoke and drink more, they engage in more reckless and dangerous behaviors, they work in more dangerous jobs and dangerous environments, and all of those factors obviously contribute to poor health outcomes, which can likely explain why men live on average 6 years less than women in the United States. Right? So let's start looking specifically at some problems of healthcare in the U.S. The United States operates on a private insurance basis, which means that you need private insurance in order to get any of your healthcare costs covered in the United States, unless you are over 65, in which case you have access to Medicare, which is a publicly funded healthcare coverage, or if you are poor and of lower socioeconomic status, you could possibly cover for Medicaid, which is another publicly funded healthcare coverage service that is designed to help people who are specifically living in poverty. And we'll talk a little bit more about those in a minute. But unlike many industrialized nations, the U.S. does not have a national system of healthcare or health insurance. So a lot of other countries, especially countries in kind of the Nordic region in Europe, use tax dollars to make access to healthcare or health insurance a right guaranteed to every citizen. So every citizen in many of those countries has access to healthcare or health insurance. It is paid for by the government because they use tax dollars to fund those things. We do not have that in the United States. The U.S. requires citizens to pay for private health insurance. I put a little asterisk by that because, like I said, if you're over 65, we do have a public health coverage system called Medicare that provides health coverage to people over 65, and we also have Medicaid, which is designed to provide health coverage for people living in poverty. But everyone else, all other adults between the ages of 18 and 65, have to pay for private health insurance out of pocket. On average, Texans pay $444 a month for their health insurance premiums, and that's just the cost for the premium that you pay a month. Having health insurance, private insurance, doesn't mean that everything is free after you pay that $444. You still have to have things like deductibles that you have to meet, co-pays for visits, and for drugs that you may be prescribed, pharmaceutical drugs. And then also, even after you meet your deductible, health insurance typically only pays somewhere between 70 to 80% of your costs, which means you're still left paying 20 to 30% out of pocket. Right? Some, but not all, employers pay for portions of monthly premiums, meaning that unemployed people and people working hourly positions pay more out of pocket for health insurance. And as a result, many lower class people, especially those living in poverty, do not have health insurance in the United States. About 10% of our population is currently uninsured. That's dropped a little bit since the passing of the Affordable Care Act under the Obama administration, but Affordable Care Act is being targeted right now, so we will likely see an increase if that gets taken away in the number of uninsured. Without health insurance, a simple appendectomy, which is the procedure to remove your appendix if you have appendicitis, could cost someone $33,000, which is obviously enough to put someone in debt for their lifetime and even enough to make some people file and declare bankruptcy. So the costs of healthcare in the United States are alarmingly high. I think I'm going to pause here and I'll start up with another video to tackle this topic.